Hello, everyone. I hope you're having a great day. Today, we're covering a high yield surgical topic, which is gaining abdominal access. This is the first critical step before any laparoscopic procedure, which will allow us to safely establish a pneumoperitoneum and begin the operation. I'll break down the pertinent anatomy, key techniques, and considerations you need to know before participating in your first surgery. Now, before we dive into the varying methods of gaining abdominal access, we need to quickly review some basic anatomy. Let's first cover some superficial anatomy of the abdomen. The first one that everyone knows is the linea alba, right here. It spans from the xiphoid process to the pubic symphysis. Next, we have the tendinous intersections, located right here, and that helps make up the envied six pack that we all want. Lateral to the rectus muscle are the semilunar lines, which are located right here, which mark the transition between the rectus abdominis and the lateral abdominal wall muscles. Approximately halfway between the umbilicus and the pubic symphysis is where we'll find the arcuate line, which is unique in regards to the layering inferior to this line. I'll discuss this in the next slide. The last landmark I want to address is a point found right here. It's called Palmer's point. This is a landmark utilized when accessing the abdomen with a Veress needle, which I'll cover in a little bit. Palmer's point is along the midclavicular line right here and is approximately 3 centimeters below the subcostal margin. Having gone over the superficial anatomy, let's go ahead and discuss the layers of the abdominal wall. It's important to know these layers because all good surgeons know what they're cutting into. It doesn't make sense to cut into a structure and we don't know what lies beneath it. So I want to first cover the layers that are found on the medial aspect of the abdominal wall. And when I say medial aspect, I refer the layers found between these brackets right here. The first and most superficial layer that we'll come across is obviously going to be skin. After that, we have the subcutaneous fat, also known as Camper's fascia. Just deep to that, we have a more membranous layer, which is called Scarpa's fascia, which lies deep again to Camper's. And then we come across the anterior rectus sheath. Deep to the anterior rectus sheath, we of course find the rectus muscle. And of course, if we have an anterior rectus sheath, posterior to the rectus muscle is going to be the posterior rectus sheath. Just deep to the posterior rectus sheath, we have this fatty layer, which is going to be our preperitoneal fat. And then finally, the deepest layer of the abdominal wall is going to be the peritoneum. Now, this is a very common PIMP question that surgeons ask medical students. They want to know if you can name all 8 layers of the abdominal wall, specifically in the medial aspect of the abdominal wall. Now, let's go ahead and learn the layers of the lateral abdominal wall, which is another common question asked to students. Here's a list of the 9 lateral abdominal wall layers. Again, we begin with skin, found superficially, and then we have Camper's fascia, Scarpa's fascia, and then we come across the first layer that differs from the medial aspect, which is going to be our external abdominal oblique muscle. Then we have our internal abdominal oblique muscle, and then deep to that we have our transversus abdominis muscle. Deep to that, we have our transversalis fascia. Now, you might be wondering, why wasn't transversalis fascia mentioned in the medial abdominal wall layers? And that's because the transversalis fascia actually is incorporated into the posterior rectus sheath. Deep to the transversalis fascia, we then again have the preperitoneal fat and then the peritoneum. And again, those are all the layers lateral to the rectus muscle. If you recall in the last slide, I mentioned a landmark called the arcuate line, which is found approximately halfway between the umbilicus and the pubic symphysis. This line represents the inferior limit of the posterior rectus sheath. If you see in this image right here on this slide, you could see that the posterior rectus sheath is present in this upper portion, but in this lower image, the posterior rectus sheath is missing. This illustrates the layering superior and inferior to the arcuate line. While you're on your surgical rotation or working in the OR, the surgeon could pimp you and ask, okay, what are the layers found inferior to the arcuate line? And then you can confidently state the layers and exclude the posterior rectus sheath. Now, this will only affect you recording the layering of the medial abdominal wall layers, because the lateral abdominal wall layers is not affected with or without the posterior rectus sheath. The last part of anatomy that I want to review is the blood supply to the rectus abdominis muscle. This is another very common PIM question asked to medical students. You need to remember that the rectus abdominis muscle gets its blood supply from both the superior and the inferior epigastric vessels. I would also review the branching of which these vessels come from. For example, the inferior epigastric vessels are a branch of the external iliac vessels, while the superior epigastric vessels are a branch of the internal thoracic vessels. Sweet. Now that we've covered all the pertinent anatomy, we can actually go ahead and learn about the different methods of gaining abdominal access. The first one I want to cover is called the Veress needle approach. It's also called the closed approach. And the way you do this is that you make a small incision at the umbilicus or at Palmer's point. If you recall, Palmer's point is 3 centimeters below the subcostal margin along the midclavicular line. You make that small incision and then you insert this Veress needle through the layers of the abdominal wall. Now, there's different tests that you could do to make sure that the Veress needle has gone through all the layers and inside the intra-abdominal space. The first one I want to mention is called the saline drop test, which I have found to be the most common. What you do is you put a little bit of saline inside this reservoir, which all of these Veress needles have right here. And inside that reservoir, you put a little bit of saline. Now, if the saline drains and flows through the Veress needle, you could confirm that you are indeed inside the intra-abdominal space because gravity has allowed that saline to flow through it. However, if you're stuck between layers or that tip of that Veress needle is between layers, that saline isn't going to flow through. It's going to be impeded and stay within that reservoir. And so you'll be able to know whether or not you're found within the intra-abdominal space or between layers of the abdominal wall. Another test to make sure that you're within the intra-abdominal space is to see if there's low initial insufflation pressure, which you could see within the monitor. The final test that I want to cover and is often asked by surgeons is the double click test, or sometimes called the double pop test. And this is when the surgeon who's handling the Veress needle will feel two distinct clicks as he or she pushes the Veress needle through the abdominal layers. If they feel two clicks, then they can feel certain that they're within the intra-abdominal space. Now, the advantages of using this Veress needle approach is that it's very quick. All you have to do is make a little incision at Palmer's point or inferior to the umbilicus, and then you just push through all those layers, and then you can confirm you're within the intra-abdominal space with either the saline test or the double click test or low initial insufflation pressure. So it leaves a minimal incision size and it's very quick. However, this is a blind entry approach, which is a huge disadvantage. You do run the risk of perforating some bowel or some viscera, or even causing a hemorrhage by damaging some vessels. In this slide, I want to return back to this image of the layers of the abdominal wall because I want to give some clarification on the double click test. When they push the Veress needle through the layers of the abdomen, the first click they're going to feel is actually because of they're going through that muscle fascia. So the first click will be here, typically around the linea alba if they're going through the medial abdominal wall. And then the second click is going to be going through the peritoneum. So again, first click, the muscular fascia, second click through the peritoneum. The same applies when they're going through the lateral structures. Again, going through those fascial layers of the musculature on the lateral aspect will be the first click, so number one. And then the second click will be going through that peritoneum, number two. So really quickly, we're going to watch how a Veress needle is used in real surgery. I'll put a link of this video in the description below so you can watch it in your own time for further review. So right here, they made a small infraumbilical incision, and then they're using that Veress needle. You can see that they went through the first set of layers, had that first click, and now they went through the second layers with that second click, and then they're going to use the test of insufflation to make sure they're in that intra-abdominal space. The next method I want to discuss is the Hasson approach, also known as the open technique. This method differs from the Veress needle technique because the Veress approach enters the abdominal cavity blindly, whereas the Hasson technique allows the surgeon to directly visualize the layers of the abdominal wall during entry. With this approach, the abdominal wall is carefully dissected layer by layer until the peritoneum is open and the abdominal cavity is entered, after which a trocar is then placed under direct visualization and the port is secured. One of the major advantages of this technique is improved safety. Because the surgeon is directly visualizing the tissues during entry, there's a lower risk of injury of intra-abdominal structures or major vessels. However, like any technique, there's also disadvantages. The Hasson approach typically takes more time, requires more instrumentation, and also the procedure is longer compared to the Veress technique. And when we're dealing with surgery, efficiency matters. Shorter operative time can mean less time under anesthesia for the patient. Another important consideration is the size of the initial incision. If the incision is too large, it can lead to the gas leaking around the port site, which may make it difficult to maintain adequate pneumoperitoneum during the procedure. This video will demonstrate how the Hasson approach is used in surgery. The surgeon makes that initial incision inferior to the umbilicus, and then with some S retractors, we're going to go ahead and pull back through blunt dissection some of those superficial layers. With the blade, we're going to go ahead and cut the next set of layers. Again, the surgeon is able to visualize everything that he or she is able to cut. The surgeon's going to then go ahead and clamp onto those deeper layers and then pull those back. And then return with the blade, cut through those deeper layers. You can see right here that the surgeon is throwing a few sutures on either side of this incision. And while they're doing this, I want you to ask yourself, why on earth would they be throwing some sutures in when we're just barely opening up this incision point? And this looks like it's going to be peritoneum. We just need to make one last cut, and we should be in the intra-abdominal space. Alrighty, and this is why. Once we put in the trocar and the port, we'll be able to anchor that port site down with those sutures by tying them on either side of the port, as demonstrated here. The last method that I want to cover is called the optical approach, or sometimes called the direct visualization approach. And this one is by far the most simplistic of the ones I've covered in this video. What you essentially do is you put the laparoscopic camera within this blunt trocar, and you're able to see all the layers that you're passing through as you dissect into the intra-abdominal space. It's super quick. I would argue just as quick as the Veress needle approach, but you gain the benefits of the Hasson approach because you're able to visualize every layer and every structure you're passing through. So this one by far, in my opinion, is the safest and quickest approach when gaining abdominal access. So we'll conclude this video by watching this demonstration of how the direct visualization approach is utilized. So again, we make that initial incision, and then there's the laparoscopic camera with the optical trocar. We're going to bring up that abdominal skin, create tension, and then we look back at the monitor and we can see all the different layers that we're passing through. And once we go deep enough through these layers, we gain that abdominal access and we can begin insufflation of the abdominal cavity. And that's a wrap on how to gain abdominal access for laparoscopic surgeries. Best of luck to you and to your studies. Be sure to come back to this channel as I'll keep uploading videos on surgical topics designed to prepare you for your surgical rotations and help you succeed in the OR.